saludo muy especial a todos los amigos y colegas de Latinoamérica que nos acompañan en esta, la última sesión de RASH 2.0. Una sesión muy especial con dos invitados maravillosos como los que hemos tenido en las sesiones anteriores. Voy a permitirme presentar al primero de ellos, el doctor Benjamín Cepeda. Es pediatra, alergólogo, académico del Hospital Federico Gómez y numerario de la Academia Mexicana de Pediatría y actual presidente de Compedia. Doctor Benjamín, bienvenido.
Gracias, Clau. Qué gusto poder estar con ustedes. La verdad es que ha sido un agasajo este curso RASH 2.0 2025. Todas las tres sesiones anteriores y esta cuarta es una locura. Y hoy estamos de manteles blancos y de fiesta, porque realmente los cuatro ponentes que tuvimos fueron de alto nivel académico. Y bueno, me encantaría presentarles al ponente del día de hoy, que realmente es alguien muy conocido en el medio, y el doctor Christophe Dupont. Él es profesor emérito, él es gastroenterólogo pediatra en Francia, y él es profesor emérito, trabaja en el Clinique Marcel Saint-Vant del grupo Ramsay en Francia. Es investigador y colaborador de más de 200 publicaciones científicas a nivel internacional, y actualmente es el presidente del Comité de Nutrición de la Sociedad Francesa de Pediatría. Realmente es un honor, doctor Dupont, contar con usted en esta sesión, en este cierre del curso RASH 2.0. Y adelante, tiene la palabra.
Mr. President, ladies and gentlemen, dear colleague, my name is Christophe Dupont. I am an emeritus professor in Paris University, and now I've got a private practice still in the region of Paris. My specialty is being a pediatric GI, and I am going to talk about the safety and efficacy of HRF formulas and the newest DRACMA guidelines. Here you can see my disclosures. I've been working for Abbott, but also for Nestle, Danone, Mead Johnson, and I am a shareholder of DBV Technology, a company which is devoted to desensitization. So the focus of this talk will be the usage of rice formulas during the nutritional management of cow's milk allergy, and to show how this kind of formula may improve the symptoms in patients with cow's milk allergy. So let's talk first about the ontogeny of rice formulas, HRF, hydrolyzed rice formulas. Well, basically, the formula which are devoted to treating children with cow's milk allergy are submitted to guidelines. These guidelines indicate very precisely the amount of carbohydrates, of fat, and of proteins, and also, of course, of vitamins and minerals. And these guidelines have been issued mainly by the European Union. You see in this slide what we have as in terms of protein part. So which protein part are we going to use during a cow's milk allergy? We cannot use the milk intact proteins because there are milk protein inside. For many decades, we have been using extensive hydrolysates based on the small peptide coming from whey proteins or casein protein, all of them coming from milk. But in this kind of formulas, you still have some milk remnants of proteins because the hydrolysis is not complete. And in some very reactive children, you still have a reactivity to these milk remnants. So if you've got this kind of problem, you can use a formula without any milk remnants. And the first amino acid formulas have been issued at the end of the last century. But now we've got something which is a little bit new, beginning of the current century, the formula based on hydrolyzed rice protein. In these formulas, you've got small peptides, but you've got absolutely no milk remnants because the proteins are coming from rice. So why choosing rice? Rice is a staple food, but it is different from cow's milk. When you look at the perception that the people have about rice as compared to cow's milk, you see that Cow's milk is considered as a very good source of protein, which is rich in calcium and in some vitamins with a high density in nutrients. When you compare that with the rice, you see that rice is considered as a source of carbohydrates, but that it is low in vitamin and minerals, low in energy, and probably not many people are thinking about the protein content of rice. But actually, rice has a huge amount of protein inside. Any food that we have around the world has a part of protein. The protein part may be important or much lower. In rice, we've got a very interesting protein part. This protein part of rice protein is interesting for two main reasons. The first main reason is that rice protein is has a very low allergenicity. And when you look at the data that you can find in the literature, you see almost no anaphylaxis with rice. Here is a request that I did last year. You can see here the request about allergenicity. I mean, rice and anaphylaxis. And you see that I have found only 2 isolated cases of rice anaphylaxis. 2 publications, but each time for only 1 case. And it was a case of food-dependent exercise-induced anaphylaxis due to rice. One was in Japanese, the other one was in English, but you see very low level of literature data about rice, indicating that when you use rice, you're almost free of any risk of anaphylaxis. The second reason why it is interesting to select rice protein is that it is a good source of proteins and of amino acids for humans. This slide is partially in French, I'm sorry about that. When you compare rice on one side and breast milk on the other side, you can see that the composition in terms of the essential amino acid is almost the same. The only difference that you see is that you see in the rice protein slightly lower level for lysine, for threonine, and for tryptophan. So that if you use rice protein to manufacture formula based on cows on rice, I'm sorry, to feed children, you need to add some missing amino acids such as lysine, threonine, or tryptophan. And of course, the addition depends on the rice species. And sometimes you may use lysine, in other one you may use threonine, and so on and so on. But basically, you've got something which is quite in good accordance with breast milk composition. So if you see what you can do with rice protein, you can actually, and this has been recognized by the European Union, you can use rice protein to manufacture a formula which is adapted for the treatment of children with cow's milk allergy because the composition is nutritionally absolutely adequate and the protein part is made of protein from rice so that it has a complete analergenicity in terms of reactivity to milk for children with cow's milk allergy. Here you can see the composition of the formulas which are based on hydrolyzed rice protein. You have here the composition of Italian formulas, of Spanish and French formulas, and also of American formulas. As you can see here, the energy is the same in all the formulas. The protein part varies according to the quality of the protein portion. You can see here that there has been a hydrolysis, so that you've got a reduced molecular weight in all the formulas that you can use. And you see that the molecular weight is quite low, below 2,000 Dalton, which is quite low. And you see that in some of them, you've got the addition of some missing or amino acid with a low level. You see that you can have an addition of lysine, in some addition of threonine, and in some addition of tryptophan. So you see, you've got here the composition of the formulas based on rice protein with, in terms of nutrition, exactly the same content that you can find in any kind of other formula dedicated to feeding children. When you've got these formulas, the first thing that you want to have in children with cow's milk allergy is an efficacy and safety. Efficacy and safety are the main points that you need to check in children that you are going to feed during cow's milk allergy, because you want them to be treated for the symptoms, and you want them to be nutritionally well, in terms of growth, mainly in terms of growth. So let's talk first about the efficacy of HRFs. The efficacy, what is it? It is the ability to be tolerated in children with cow's milk allergy. We have several clinical trials which has been performed with HRFs. This one was done by Alessandro Fiocchi, an Italian researcher. This one also by Alessandro Fiocchi. Here, this one, Spanish trial done by Recce, and this was a clinical trial made by Yvan van den Plas in Belgium. You can see here 18 infants, 100 infants, 92, 36. You see that in all of them, the results were quite positive. 100% tolerance in this one, all challenges negative in this one, 100% tolerance in this one, and 100% tolerance in this one. It is interesting to see that we have more recent clinical data now, and the clinical data that we have now, the more recent clinical data that we have, is the clinical trial that was done by Dr. Ramirez Farias, and who analyzed the tolerance and growth. We will see the growth afterwards, but analyzed tolerance and growth in children fed by the new formula marketed by Abbott. This formula is based on rice protein, and it is enriched in 2FL. You see this human milk oligosaccharide coming, which has been found in breast milk. What is interesting in this clinical trial is that the recruitment of children was based on symptoms which indicate exactly the symptoms that you can see during cow's milk allergy. You see you've got mainly reflux here and constipation. And it is my experience that most children with cow's milk allergy have got reflux and constipation. But you can see also that some of them had diarrhea, some had blood into stool, very few actually, and some have colic, and colic is a very prevalent syndrome in children with cow's milk allergy, mainly during the first months of life. And of course, when you've got cow's milk allergy, you may have eczema. You see approximately 25% of them had eczema. And you see that all these symptoms more or less resolved following the use of an HRF, so indicating that basically you've got a good approximation, the good association between the resolution of the symptoms that you can see during cow's milk allergy, and the evolution of children when they're fed with an HRF. So we've got the efficacy. Now let's talk about safety. Safety, what is it? It is the ability to ensure normal growth in children with cow's milk allergy. Why is it very important to focus on the growth in cow's milk allergy? This is mainly because the major growth that you can see during the life of any individual is during the first months of life, as you can see here. So if you've got a delay in the growth of children during this period, this deficiency in growth might persist during all life. And if it persists during all life, it may be responsible for a lower height at adult age in children with cow's milk allergy. And basically, this is what we see when we analyze clinical trials analyzing the growth of children with cow's milk allergy. You see, this is a clinical trial that was done in the US. You can see that more than 6,000 children were analyzed. They had cow's milk allergy, and they were analyzed in terms of weight for age, in terms of height for age, and in terms of BMI. And you can see here the comparison between non-allergic children and children who are or have been allergic to cow's milk. And you see that there is a decrease in weight for age, in height for age, and in BMI in these children who have been treated or not treated, who have been presenting cow's milk allergy. So this indicates that when a child has got cow's milk allergy, the child is at risk for growth impairment, so that it is very important to take care of this from the beginning of the appearance of the symptoms. So all the clinical trials that have been done with the H or F were intended to analyze the growth of children fed with this H or F. You can see here that we had growth from 2 studies in healthy children, which showed that growth did not differ between controls and growth standard. You can see that 8 studies assessed the growth in children with cow's milk allergy. Most of them had shown a similar growth, even though in one of them we had a lower protein content. The only criticism that we can have on these studies is that the number of the study is small. So that probably what is important to do now is try to have more clinical trials to try to be able to show that we really do not have any problem of growth. But when you will look at this data, really we can be confident. We have 2 recent clinical trials that have been performed, and one of them has been published very recently at the end of 2024. This study was a double-blind randomized control trial during 12 months of feeding with a rice hydrolyzate in 100 children in 6 different sites. And in these children, there was a very nice analysis of the weight gain, the height gain, many other parameters also. I'm not going to show them to you. And the follow-up was during 12 months. And you can see in this slide that there was absolutely no problems in terms of weight gain and in terms of height gain. And when the researcher compared the evolution of children fed with an H or F or fed with an extensive hydrolyzate based on cow's milk, actually the growth was similar in both. So that with the H or F, based on this quite large trial, we may be confident that we have a good growth gain with the H or F. Another clinical trial, the one by Dr. Ramirez Farias, I've shown before the results in terms of efficacy, ability of the formula to reduce the symptoms. Here we are going to see the same clinical trials, but we will focus on the growth. And you can see here something which is interesting. At the beginning, when the children were enrolled, the weight and length was approximately normal. Perhaps they were a little bit taller than the normal in children who would be allergic to cow's milk later on. When children were enrolled in the clinical trial, they had a deficiency in weight and in height. And following 1 month of treatment with the formula, you can see here that there was a nice catch-up. So basically, again, with this short clinical trial, you can see that you have a very nice catch-up in terms of growth. So we have efficacy, we have safety, and there is a question that many people are interested in this question is there some kind of immune modulation with milk? Actually, with the rice formulas. Are the rice formulas able to modify the acquisition of tolerance? Many people are interested in that, and this was analyzed in the clinical trial, which is for which the first author is Anaïs Lemoine. And you have here a very nice analysis of this acquisition of tolerance. The acquisition of tolerance was monitored, as you can see, during 2 years, and this acquisition of tolerance was monitored by oral food challenges. When you look at the acquisition of tolerance, you can see that it takes some time for cow's milk allergy to disappear. You see it lasts in some children. In at least 25% of them, during 2 years. And you can see that there is no significant difference between the acquisition of tolerance in children with a rice hydrolyzate and those fed with an extensive hydrolyzate, showing that basically you do not have any difference. This is very important to know because some people tend to think that it might be interesting in children with cow's milk IG to use an extensive hydrolyzate based on cow's milk because it could speed up the acquisition of tolerance. And you can see here that there is absolutely no speeding up of the acquisition of tolerance with the extensive hydrolyzate based on cow's milk. There is even a slight tendency, but we're not going to argue on that slight tendency for a quicker acquisition of tolerance with HRF. So absolutely no modification, in my opinion, absolutely no modification in the acquisition of tolerance. And the demonstration by this clinical trial that when a child is being fed with an a rice formula, the rice formula may be kept until the end of the disease, at least until the end of 2, perhaps in some children, 3 years. So now I think at the beginning we had with the rice formulas only our own experience. We didn't have a recommendation, the different guidelines, because these rice formulas have been marketed very late. I mean, following the extensive hydrolyzate based on cow's milk and following also the amino acids, the rice formulas have been marketed only from the beginning of the current century, so that these formulas did not appear at the beginning in the recommendation and guidelines and so on and so on. You've got an association of people working on cow's milk allergy, and these people are working in the DRAGMA association. DRAGMA means people working for the treatment of cow's milk allergy. The DRAGMA guidelines has been published before, and many efforts have been done recently to reset these guidelines, so that new publication came in 2022 and more recently in 2024. I mean, analyzing very precisely all the different aspects of cow's milk allergy. And these guidelines are very interesting because they are based on the World Allergy Association, and this World Allergy Association has formed these DRAGMA guidelines as a multidisciplinary guidelines. It was based on a panel which was balanced to include all the stakeholders of cow's milk allergy. I am part of this, and I can tell you that we are many people working on that. It is more or less sponsored by a university, and this university is specialized in a technique for which the name is GRADE, Grade or Recommendation, Assessment, Development, and Evaluation. And these recommendations are based not only on the publication, but also on the appreciation by stakeholders of the problems and way of treating children with cow's milk allergy. And the questions that have been prioritized were according to the clinicians and the patient. So you see something which is very supportive of cow's milk allergy problems. So you can see here the publication that was done in 2022, recognizing the fact that rice formula may be used now in cow's milk allergy. You see, the first proposition is that when the breast milk, while breast milk is the best source of nutrition for infant with cow's milk allergy, when breastfeeding is not possible, a hypoallergenic formula can be used. Everybody agrees on that. Second, a hydrolyzed rice formula is cow's milk protein free. We know that. A minority of infants with IG-mediated cow's milk allergy react to extensive hydrolyzed formula. I've shown that before. And more infants with non-IG-mediated cow's milk allergies than IG-mediated cow's milk allergy react to extensively hydrolyzed formula. So this sets up the pace for the potentiality of a new formula, especially the rice formula. So it's not surprising to see that the second slide shows that when the diagnostic elimination is indicated, hydrolyzed rice formula can be used. The star indicates that this has been recognized by the European Union. A hydrolyzed rice formula can be recommended as first-line option for cow's milk allergy. Hydrolyzed rice formula have proven allergenicity, hypoallergenicity, and these formulas also have been shown to support growth in infants with cow's milk allergy. And now I'm going to share my clinical experience with HRF during cow's milk allergy. I would like to show you two clinical cases. The first one is on multiple non-IG mediated food allergy, and the second one is on multiple IG mediated food allergy. So the first case is about food protein-induced allergic proctocolitis, FPIAP. This is a non-IG mediated disorder. People know this syndrome usually. The child was born with a normal birth weight, normal height, was born at term, was breastfed, which is absolutely normal, and was also fed with a formula. So there was a small problem because the child was breastfed and was more or less refusing the formula feeding. Food refusal, difficult feeding. At 1 month, the child had rectal bleeding, and the mother started an elimination diet. She eliminated any milk, cow's milk, eve's milk, goat's milk, also beef, veal, lamb, and soy. And the rectal bleeding disappeared. So basically, when you see that, you consider that it is an entity that everybody knows, breast milk colitis. The scientific word for that is food protein-induced allergic proctocolitis. So in this child, weaning started at 4 months of age. The child was fed with a formula based on a milk extensive hydrolyzed, of course, because the child was allergic to cow's milk, and rectal bleeding started again. So the child was sent to a specialized consultation, actually my consultation, and the child was doing quite well, but had only abdominal distension. So I decided to switch the child to an HRF, the hydrolyzed rice formula, and I did some patch testing. This condition is not IG mediated, so that the skin prick test, I'm not going to show you the skin prick test, but they were all negative. So that I did the patch testing. You can see the result. Actually, I analyzed many different foods. You can see here the result of the patch. Here is the control. Here are the different foods that have been analyzed. And what I saw was that the child was actually allergic to milk, of course, to wheat also, and to soy. So the child was on elimination diet for milk, wheat, and soy. He had a normal growth, and at 1 year of age, he had a milk challenge and was proven not to be tolerant to milk. So that I was able to switch the child to what we can call a toddler HRF. We have that in France, HRF, which is adapted to children above the age of 1 year. And the child was fed with a prolonged milk-free diet with a gradual reintroduction of milk using the milk ladder. You see this process according to which you introduce first a well-cooked milk before going to fresh presentation of milk. And you can see on the chart that the growth was absolutely appropriate in this child. Second clinical case is a child with eczema. So we had a child with exclusive breastfeeding. The child was having eczema from 1 month of age, and at 3 months, he had the first bottle of standard formula. And 15 minutes later, there was a generalized erythema, crying, and the face edema. The child was treated with antihistamine, with oral steroid, and the day after, he had an eczema flare-up. He was tested and switched to tested with an HRF, didn't have any adverse reaction, so that he was progressively switched to the HRF with a progressive tapering of breastfeeding. At 5 months of age, we had another allergy worker. before starting complementary feeding, and it appeared that the skin prick tests were positive for milk, egg, wheat, and peanut. At that moment, the child was consuming 500 milliliters per day of HRF, and the complementary feeding was made with elimination of milk, egg, wheat, and peanut. We had another workup done at 8 months, a second allergy workup actually, and the skin prick test was still positive, as you can see here, for milk, for egg white, for egg yolk, for wheat, and for peanut. It was negative for some other allergen that may be positive in this kind of child. We have an increased level of total IgE, and we had highly increased level of specific IgE for milk, for egg, for wheat, and for peanut. So this child was highly allergic to different foods with a system in which it has the increase, the allergy was manifested by the increase of specific IgE to many different foods. And the child was still absolutely able to drink the HRF without any problem and without any modification of the clinical appearance of the child. At 8 months, 16 months, and 24 months, we had the follow-up. You can see that you have a progressive decline of the total IgE. In parallel, we have a progressive decline in the level of specific IgE for milk, for egg, for wheat, and for peanut. You can see here at 2 years of age, 11.2 for milk, 13.2 for egg white, and for wheat, 4.95. Sadly, for peanut, we didn't measure that because the skin prick test was very positive, and we knew that the child was still allergic to peanut. And you know that allergy to peanut is something which is very related to severe eczema. So at 24 months, we had the introduction of wheat. It was okay. At 26 months, we tried milk. This triggered urticaria. So we were able to go on with the elimination of milk, egg, and peanut. And during this time, the child was still having a daily consumption of 400 milliliters of HRF without any problem. So you can see here that we had the presentation of children with non-IgE-mediated cow's milk allergy and also IgE-mediated cow's milk. And when you look at the last recommendation that have been done with DRACMA, you can see these recommendations here. The first one, when choosing a formula for infants with IgE-mediated cow's milk allergy who are not being breastfed, we suggest an extensively hydrolyzed cow's milk formula or a hydrolyzed rice formula as a first option, and an amino acid formula as the second option. Recommendation number 2, when choosing a formula for infants with non-IgE-mediated cow's milk allergy who are not being breastfed, we suggest an extensively hydrolyzed cow's milk formula or hydrolyzed rice formula as the first option, amino acid formula as the second option. You see, so these recommendations made by DRACMA last year, actually in December last year, show that very precisely when we have a child with allergy to cow's milk, IgE-mediated, non-IgE-mediated, in both conditions, we can use a HRF, a hydrolyzed rice formula. And this will be my conclusion. The HRF, they are adapted to IgE-mediated and non-IgE-mediated milk allergy. The efficacy with milk allergy has been proven, even when we have multiple food allergy, even when it is severe. These formulas, HRFs, are able to ensure a normal growth in milk allergic children. HRFs may be used on first intention, this is very important, or in case of allergy to milk protein extensive hydrolyzed. And very important, these guidelines, the guidelines now, international guidelines now, include HRF as products that can be used first intention in children with cow's milk allergy. I thank you for listening to me.
Thank you, Dr. Christophe Dupont. It was a real pleasure and an honor to have you here in this RASH course 2.0, and we really enjoyed the very important points that you say in your presentations. And we have a lot of questions right now, and I'm going to try to make the most important ones. And first of all, considering the first two options proposed by DRACMA guidelines for safety and acquisition of tolerance, when we should choose an extensive hydrolyzed cow's milk protein formula, or when we have to choose an extensive hydrolyzed rice formula to begin the treatment for a baby who has cow's milk allergy. I think it's a very nice and a very important question that almost all the people and the pediatrician makes when we have to choose one formula with cow's milk protein and with rice protein.
So you want me to answer now, yeah?
Yeah.
Yes. Thank you for asking this question. This is a very important question, and I understand that many people are wondering whether they should use an extensive hydrolyzed based on cow's milk or an extensive hydrolyzed based on rice. I have got. It's difficult to say. It's difficult to answer very precisely. And as you can see here in the DRACMA guidelines, the recommendations are very cautious about that. What we can say is that when a child is allergic to cow's milk and is very young, the child is able to tolerate formula based on cow's milk. The taste is not very good, but the infant may be adapted to that because the taste of the child has not, of the infant is not yet developed, you see. So that you can start an extensive hydrolyzed based on cow's milk. When the child is older and when complementary feeding has started, then it is very difficult to start an extensive hydrolyzed based on cow's milk. And very often, at least in France, we use a rice formula. But you can use also a rice formula in children before the age of 4 months. So it's your choice. In France, we have a difference between the rice formula and the milk formulas. In France, the rice formula are not reimbursed by the Social Security, and the extensive formula based on cow's milk are reimbursed by the Social Security. So considering the family, the income, different incomes, and so on, we can switch from one formula to another. But I can say that the guidelines at the moment do not precisely say if you have to go first to the rice-based or to the milk-based extensive hydrolyzed.
Yeah. You have two options, and you can either
two options.
start
Yes,
with one or the other one. Yeah.
Basically, if the child is very young, you can use the milk base because the taste is not an issue. If the child is older than 6 months, you will not succeed with an extensive hydrolyzed of cow's milk. So it's very good to have the rice formula.
Perfect. Thank you. Yeah, it's a real difficult questions to make, but almost all the people make it. Yeah, but thank you so much. Another question: what would be the minimum age complete the 6 months of a cow's milk protein exclusion treatment, at which we challenge the baby to be tolerance acquisition? So if we have the 6 months of exclusion, and then what is the minimum age we can make or start the challenge to be a tolerance acquisition?
When this is an IgE-mediated cow's milk allergy, then you can monitor the reactivity of the child by measuring the specific IgE. So if you see that there is a very nice decrease of a specific IgE, you may consider reintroducing milk. And it is considered that when you have a decrease year after year or 6 months after 6 months of the level of specific IgE, this indicates that you are going to the acquisition of tolerance, and very soon you are going to be able to reintroduce milk. When it comes to non-IgE-mediated cow's milk allergy, the situation is different because acquisition of tolerance comes usually sooner, from 9-10 months of age, so that you can start reintroducing milk from 9-10 months of age. The important point now is to know that when you try to reintroduce milk, you do not do that with fresh milk, with a bottle of fresh milk. You do that using what we call the milk ladder. You start first with the cooked form of milk. Milk, for example, in biscuits, or milk cooked in any kind of cake with milk inside. And you rely on the fact that when the product is cooked, you've got a decrease of the allergenicity of the food. So reintroduction, I mean, years ago was done using a bottle. Now it's not anymore done like that. It's done using this milk ladder. You start with a biscuit. If the biscuit is okay, then you go to a cake where the cooking temperature is a little bit lower, and then progressively you go to fresh presentation of dairy products.
Perfect. Yeah, we have to see the evolution of the baby, see if it's an IgE or not IgE mediated, and then make the letter. And it's so nice because some cases the people is like with nervous and they don't know how to start the challenge. No, thank you so much, doctor. And another one, it's do you want to point out, in the light of the new Drachma guidelines update, what would be the cases in which we should ask the mother to follow an exclusive diet of cow's milk protein?
Okay, so the mother, we've got different situations. A situation where we want to, for example, try to prevent cow's milk allergy in the family where you've got a risk of allergy. Actually, I think we don't have data at the moment to say that it is better for the mother to drink milk or not to drink milk. All the data that we've got are coming from clinical trials that have been done at least 20 or 25 years ago. And now the food has completely changed. It is ultra processed and so on and so on. So I think that what we had, I mean, the clinical trials that we had before, we cannot rely on that. So that recommending for family with a high risk of allergy, recommending anything to the mother at the moment, is very difficult. But when the child is being fed by breast milk and the child has the symptom of cow's milk allergy, then you can start the elimination of cow's milk in the mother. What you do is that you ask the mother to remove cow's milk completely. You ask the mother, if you succeed, it is okay. If you do not succeed, you can ask the mother to remove another food. And very often you've got problems with egg, wheat, and soy. I mean, these are the main ones. And when the child is okay, which is most of the time the case, when the child is okay, you can say to the mother, you can tell the mother that she can reintroduce in her own diet these cooked form of the different foods, like cooked egg, cooked wheat, cooked milk, so that the diet of the mother is not too much complicated. She may go on with breastfeeding with a diet which is not completely free of this product, like milk or wheat. She can still have them, but in the cooked form, which is not offending for the child.
Perfect. Yeah. Yeah, it's a very interesting things that we have to make, and almost we have a lot of information. And thank you so much to be here in this very important course. And I really appreciate your presence, Dr. Dupont, and I will see you in some place in the world, because you are a very important guy. So I know you're going to be maybe next month here, and thank you so much. It's a really, really pleasure to be here.
Very good. It was a pleasure also to have this discussion and talk with you. See you someday, somewhere. Okay?
Yeah, thank you so much.
Bye-bye.
Bye-bye. ¿Qué tal? Pues realmente un placer. Cerramos con broche de oro este curso RASH 2.0. La verdad es que quedo muy satisfecho y muy agradecido con todos los ponentes que tuvimos de alto nivel académico y el cierre con el doctor Christophe Dupont fue espectacular y creo que realmente quedan muy claras ya los puntos de cómo manejar a los bebés con alergia a proteína de leche de vaca, que en los últimos años hemos visto un aumento en su prevalencia y entonces cómo entender esta clínica y este tratamiento que tenemos que llevar a cabo. Y bueno, fue un placer tenerlos estas 4 sesiones para mí, para Compedia, el Colegio Mexicano de Pediatras Especialistas en Inmunología y Alergia. Fue un honor poder contar con esta participación, con el apoyo de Abbott. Gracias a todos por conectarse, por estar aquí en estas sesiones semanales. Y recuerden que tiene puntos de certificación por parte de Cónica. Y bueno, son 4 puntos los que tenemos que seguir. Uno es, se tienen que ver, o sea, meterse primero a la página porque van a estar ya on demand, ya sea que las hayan visto en vivo o on demand, pero van a estar on demand. Tienen que registrar que hayan visto las 4 sesiones y estas estarán vigentes hasta el 16 de junio. Y posteriormente que ya pudieron ver las 4 sesiones y que está registrado que las vieron, se pueden ir a la sección donde dice certificado. Y aquí van a venir 2 cuestionarios. Uno, el cuestionario de satisfacción en cuanto al curso y el cuestionario en cuanto a preguntas específicas sobre el tema que estuvimos viendo en cuestión que es alergia a proteína de leche de vaca y su tratamiento. Y ya en cuanto esté esto y se manden, en una semanita aproximadamente estarán llegando sus certificados al correo electrónico con el cual se registraron. Y bueno, invito a la doctora Claudia Sánchez, que fue la coordinadora oficial de este curso RASH 2.0 2025, para que nos dé unas palabras de despedida. Clau, estoy eternamente agradecido contigo y con todo tu staff. La verdad fue una gran labor, fue un gran curso, gran información y gracias por estar aquí con nosotros un año más.
A ti, Benjamín, muchísimas gracias a Compedia por este maravilloso curso, realmente puntos muy claros, actualización, estamos esperando hace mucho las guías Dragma, entonces poderlas socializar y sobre todo con este curso que nos permitió poner con casos clínicos en evidencia la aplicabilidad de las guías y de su actualización. Muchas gracias por el apoyo académico que es muy valioso y muchas gracias sobre todo a todos los que nos acompañan hoy en las otras sesiones hacer realidad estos espacios de construcción de conocimiento. Todas sus preguntas y los momentos de discusión son muy valiosos para generar conocimiento. Entonces, muchísimas gracias por su apoyo, a todos los que se han conectado, por el interés académico y por los aportes. Una feliz noche a todos.
Gracias. Saludos.